Welcome to the ECG 5-Minute Consult, brought to you by myself, Sung-Young Hiva Lee, and Dr. Bill Hayden, co-author of ECG for First Responders, now available on Amazon. Let's get started on today's case. Today we're continuing with our next segment of 10 deadly signs on ECG, abnormal findings that must not be missed. Awareness is the first step in preventing cardiac disasters. You arrive on scene responding to an emergency call for a 59-year-old man who collapsed while golfing. According to bystanders, the man complained of sudden chest pain, vomited, and then fainted. After the man had fainted, his golf partner immediately began CPR. No palpable pulses detected, and on EMS arrival, quick-look defibrillator paddles were applied and revealed a unique rhythm seen below. Let's test your knowledge. Which of the following is the most appropriate next step in management? A. Secure airway and begin immediate ventilation. B. Administer epinephrine 1 to 1000 IV push. C. Synchronize cardioversion. D. Immediate defibrillation. Or E. Establish IV/IO. The correct answer is D. Immediate defibrillation. After administering immediate defibrillation, a pulse is reestablished and an on-scene 12-lead ECG has been taken. Before we view the ECG, let's review our primary survey approach. Using the ECG primary survey approach, first responders should address these 4 questions. 1. The rate. Is the heart rate too fast or too slow, causing signs of shock? 2. Rhythm. Is the rhythm supraventricular or ventricular in origin? 3. ST segments. Are the ST segments consistent with an ST elevation myocardial infarction or a non-ST elevation myocardial infarction? And 4. T waves. Are the T waves consistent with an STEMI or an NSTEMI? First, let's look at the rate. You can estimate most heart rates by applying the 300, 150, 100, 75, 60, 50 sequence. In this case, the peak R waves are slightly more than 3 large boxes apart, so we can estimate the rhythm is about 90 beats per minute. You can also estimate rhythms by counting the number of QRS complexes that occur during a 6-second time period and multiplying by 10, supporting our estimate of approximately 90 beats per minute. Next, let's look at the rhythm. The QRS intervals are narrow as defined by a width less than 3 small boxes. Because the QRS intervals are less than 3 small boxes, we can deduce that the rhythm is supraventricular in origin. Remember, ventricular rhythms are inherently unstable and may result in sudden cardiac arrest. Next, let's examine the ST segments. The ST segments are elevated in leads V1 through V4 and AVR. The reason that the ST segment in AVR is elevated, though not one of the anterior leads, is probably best left for another discussion. ST segment depression is seen in leads 2, 3, and AVF. Remember, changes in ST segments may indicate different cardiac conditions, for example, myocardial ischemia or infarction, pericarditis, or ventricular hypertrophy. Next, let's examine the T waves. T waves are visible, but their interpretation is ambiguous, as some lie within the ST segment changes mentioned previously. Let's test your knowledge. In the paramedics report to the hospital, which of the following 2 pieces of information is the most critical? A. IV route secured. B. Number of defibrillations before return of circulation. C. STEMI alert. D. Secured and intact airway. Or E. ETA. The correct answers are B and C, number of defibrillations before return of circulation, and STEMI alert. The initial rhythm is pulseless ventricular tachycardia. Per ACLS guidelines, current recommendations advise immediate defibrillation and ventricular fibrillation/tachycardia. In this case, the rhythm with pulse returned. Here are important takeaways from today's case. Report to medical control the return of spontaneous circulation after defibrillating a patient in cardiac arrest. STEMI alert to the hospital is important so that catheterization laboratory resources can be immediately activated. The bulk of the left ventricle composes the anterior wall, with blood supply that derives from the left anterior descending coronary artery. This artery supplies most of the blood to the left ventricle and to the septum that divides the left and right ventricles. Blockage of the left anterior descending coronary artery may lead to heart block, as well as to sudden cardiac death from ventricular fibrillation/pulseless ventricular tachycardia, hence the LAD's nickname, the Widowmaker. ST segment elevation in chest leads V2, V3, and V4 indicate left anterior descending coronary blockage. ST segment depression in leads 2, 3, and AVF may indicate a reflection of the anterior V leads, together suggesting a significant anterior wall myocardial infarction. That wraps up today's segment of the 10 deadly signs on ECG, abnormal findings that must not be missed. Stay tuned for our next installment. Thanks for joining us for this installment of the ECG 5-Minute Consult. For more information, check out ECG for First Responders, available on Amazon. Until next time.